Good evening. On the behalf of Spine Society Delhi chapter, we welcome you all to the third master series in the teaching program. It is our endeavor to engage young orthopedic neurosurgeons, spine surgeons, and physicians in basic spine pathologies and bring you the best in the world people here to speak on such things. Before wasting time, I'll hand over to our convener and the secretary of the association, Dr. Mahapatra, to introduce the faculty and tell us about the program, how they can put up their questions and how it will be tackled. And I request all the faculty, please stick into the time so you don't intrude into others' time and we cover all the topics in detail. Thank you and welcome all.
Hi, good evening. I welcome all the distinguished faculties for this third webinar masterclass series by Spine Society Delhi chapter. And we have very distinguished panelists and speakers today. In fact, we have two past ASSI president, Dr. Shankar Acharya and Dr. Arvind Jayaswal, and a very elite group of speakers. So without wasting further time, I would like to ask Dr. Gururaj to start the webinar.
Okay. Thank you, Dr. Mahapatra. And we'll start this session on PIVD today. And you have a chat box and you can type your questions there. And at the end of the session, we'll be taking the questions because whatever questions you are going to put up may be covered in subsequent talks. So we'll just finish all the talks first and then we'll take up the questions. So we'll start with the first talk by Dr. Abhishek Kashyap. He is going to talk on pathophysiology of PIVD with pain generators. Thank you. Over to you, Dr. Abhishek.
Thanks, Guru.
Abhishek, you need to share your screen. Yeah, it's there.
So I'll be speaking about pathophysiology and the natural history of lumbar PIVD. This is going to be a more of an in vivo talk translated to in vitro your treatment protocols. So if you look at PIVD and its impact on back pain is that it has a big socioeconomic problem. Everyone in its lifetime would be suffering from back pain. So it will lead to reduced productivity, absenteeism. You need to change lifestyle factors, age-related changes cannot be altered, and the degeneration of an intervertebral disc will keep on happening. So if we look at the pathophysiology, to a basic understanding is that a herniated disc can press on the nerve and it may cause pain, numbness, tingling, and weakness. And it is usually called as sciatica. Herniated lumbar disc may also cause back pain, although back pain as such is not a feature of a herniated disc. We have total 23 discs. The main function is it is a hydrostatic load-bearing and shock-absorbing structure between two vertebral bodies. If you look at the disc unit, it is basically composed of the two end plates and then the annulus fibrosus and the nucleus pulposus. So the nucleus pulposus basically acts as the shock absorber and takes care of the central, and the annulus fibrosus basically it is like the fibers act in barrels, are like a barrel, so they prevent the pulposus to collapse. The cartilage end plates give main nutrition, and there are now studies which are coming in which shows that the end plates are the main region where the first hit starts, and it may lead to a disc prolapse. So nucleus pulposus, if you look at it, is a semi-fluid mass. It 70% to 90% is water, and the rest of is collagen. and it's mainly consists of proteoglycans, which are the small proteins and which lead to viscosity and hydration of the nucleus pulposus. And as it degenerates, the proteoglycans get converted into other the other molecules, and it leads to degeneration. If you look at the annulus, it has two layers. One is the inner annulus and the outer annulus. The inner annulus is basically type 2 collagen, and it is poorly structured collagen, so it is weak. Whereas the annulus, the outer layer, is basically type 1 and it is highly structured collagen. If you look at the regional variability of an annulus, which contributes to factors which lead to annulus fibrous weakness, is basically there is posterior, the annulus is thin as compared to the annular annulus, which is anteriorly quite thick. There is increased lamella, and the aging effects leads to loss of elasticity, which may contribute to a disc prolapse. There are other biochemical factors which we keep on working as we go ahead. If you look at the end plate, it's basically avascular, and it is basically which provides nutrition, and the nutrition goes to the disc through diffusion. So it has been now believed that the first hit usually starts at the end plate and it leads to degeneration, and this probably leads to a disc prolapse. So if you look at a definition of what is a disc herniation, it is basically a tear in the outer fibrosis, annulus fibrosis, and the nucleus pulposus bulges out, and which causes compression of the nerve root. This is the basic definition of a disc herniation if you look at the pathology wise. If you look at the pathophysiology, disc degeneration can be contributed because of many factors. Age is one. Precipitating factors can be because of activity, occupational stress, and chronic degeneration. If we look at the disc degeneration, which probably will start seeing degeneration at the earliest as the 11 years of age. And as you progress, almost 10% of the disc would be degenerated by 40 years, and 70 years, almost 60% of the disc would be degenerated. If you look at the morphology of the disc herniation and do a cross-sectional study, if you look at the herniation, what is it composed of? The herniation is basically composed of the herniated material. Then it all has the inflammatory tissue. It has the macrophage inflated granulation tissue. It has a neovascularization. It has inflammatory factors. And all these will have a bearing on the pathology, and it will lead to the symptoms. Either they can be pressure related symptoms, or they can be because of the chemical chemotactic factors and the chemical factors. The pressure on the nerve root basically can contribute to pain, which is a sharp burning pain. There is a nerve dysfunction, which can lead to motor loss modalities. There can be sensory loss also. Chemical factors leads to a pain-like sensation, and it basically predisposes the nerve to more pain. The nerve becomes inflamed, and when you do an SLR, so the nerve is inflamed, and therefore the patient would present with pain. So there will be physiological effects of this these chemical factors. We'll further go on and see. So if we look at what models have predicted, because this is all the pathological models, they were done basically on dogs and pigs. So they found that if you look that the pressure basically leads to induced nerve conduction, the nerve conduction velocity decreases with the pressure. In 1975, they found that a nerve study highlights the nerve root sensitivity to pressure. Then they introduced two models where they used a balloon and they placed it along the nerves and further tethered it with a plexiglass. And they measured the pressure, and they found that even a 10 mm pressure can lead, if it is for chronic. So the nerve basically adapts, and the changes, it will not lead to drastic changes like any deficit. For an acute compression to lead to a deficit would be somewhere around 100 mm of pressure, which would be a large herniation, which can cause acute symptoms. If you look at why cauda equina happens, is because it is now believed that it usually a disc prolapse happens in a tight canal which leads to a cauda equina symptom. And it is more like a compartmental theory of the compartment pressure theory of a disc prolapse. Now, if we look at the pressures which lead to changes, these are all from pig and dog models. If we look at the pressure changes, the acute pressures are the worst versus the chronic pressures. They basically lead to adaptation, neuromodulation, and they adapt over the period of time. If you look at compression at single level and two level, the two level compression is more worse than a single level compression. And if you what are the pathologies which happen because of the pressure? If you increase the distance between the two segments, then the deficit chances also increase. Is contributed by circulatory compromise and blood flow at the microcirculatory level in the nerve, and this leads to decreased nerve conduction. As believed, since I'm talking about in vivo, which is translated, if you do a ligature placement on a nerve, this was done in rats, and it was seen that it induced no pain. So pressure alone does not cause features of PIVD. It has to have some kind of an inflammation. So when a chromic catgut was placed which caused inflammation, it lead to pain induction in those rat models also. So there is a chemical theory also backing lumbar radiculopathy. There are multiple chemotactic, the cytokines and the chemokines which are responsible. If you take a nucleus pulposus and you apply it on the nerve, basically it leads to reduced nerve conduction velocity, axonal changes, leads to endoneural fluid changes, and leads to a reduced blood supply. How it induces pain is because it leads to mechanical deformation around the dorsal root ganglion, subcellular mechanism there because of ion changes and serotoninogenic transmission. TNF alpha is also considered as one of the main factors which leads to induction in pain mechanism because of a nucleus pulposus herniation. So when we look at all these strategies which were seen to whether they would stand the test of time and whether these strategies can be further taken about, all these strategies targeting the inflammation have been under scrutiny and they have not stood conclusive trials. It is because there is a big complexity of the lumbar radiculopathy, heterogeneity of the radiculopathy, and they are basically experimental models which could not be translated to human studies. Novel drugs have come, but this have not stood the standard care, and they have not stood the standard protocols that they can be translated to in vivo studies. If you look at the anatomical classification, they are basically, you have a disc degeneration that produces a bulge, then it goes to a protrusion, and the protrusion goes to an extrusion. So the nucleus pulposus has basically come out, but the nucleus pulposus is still maintaining continuity with the central core. In a sequestered, the disc, the pulposus is out of the nucleus pulposus of the annulus, and it is basically inside the canal. So this would be a severe, if you look at the severity of a disc herniation, this would be considered as a more severe kind of a disc herniation as compared to a degeneration. Whether it translates to the symptoms or not has not been proven by many people. So if you look at what is the natural history of a lumbar disc herniation, there have been many studies which have shown that even if you do not do anything for the disc and you leave it as such, the 75 to 100% broad-based protrusions would spontaneously regress. And but whether they translate or not is not shown in many other studies. All high regression is seen in extrusions and sequestration as compared to just bulges. So there was a study which was done by Takadia, which showed that most of the herniations remained unchanged over 4 to 8 years with serial MRIs. So if we look at whether regression of the disc herniation would happen or not, it needs to be seen whether how big the inflammation is, what are the imaging characteristics is, If you have a big contrast enhancement which show that the inflammation is more, then the disc would probably regress. Focal protrusion and bulges usually do not regress. Extrusions and sequestrations usually. Yes, sir.
Can we finish it fast?
Just 1 minute, sir.
Thank you.
If you look at the bacterial infection, this is another translation which has shown that people have taken samples and they've done the analysis. But whether you can give antibiotics on is controversial, it is not recommended. So if you look at the natural, it is multifactorial and it leads to degeneration. There is microinstability and macroinstability. Sorry. This dysfunction can further progress to disc herniation and can contribute to other symptoms and other pathologies. So it is basically the lumbar pathology is basically a big spectrum which shows from an internal disc disruption to a degenerative disc disease to a disc herniation, LCS with a degenerative scoliosis or spondylolisthesis, and further lead to kyphosis. So if we look at the mechanisms, you have multiple mechanisms, but have they been able to translate to in vitro studies is still questionable. Thank you so much.
Thank you, Dr. Abhishek. Now I would invite our past president, ASSI, Dr. Shankar Acharya sir, to give his talk on one of the most controversial topics. That is why we choose two past presidents of ASSI, and he's going to talk on evaluation and decision making, which is like nobody will agree with one decision. So over to you, Dr. Shankar.
Guru, just before Dr. Sankaracharya starts, I'd just like to inform that the talk by Dr. Sanjay Rajan will not be there because Sanjay could not come and be available. So his talk will be taken over and will be covered by Dr. Arvind Kulkarni in his video demonstration. Thank you.
Yep.
Okay, thanks Guru for inviting me and asking me to talk on this subject. Since my talk is clinical evaluation and decision making, I thought I would start with can you see my full slide?
Yes, sir.
You can see, na?
We can see, sir. We can see.
We can see, sir.
Okay, so let's. क्या हो गया? अच्छा. So let's say there's a 45-year-old man. This is most likely postgraduates and young surgeons who are sitting in the audience or listening to this. A 45-year-old man who presents with back pain, leg pain, with or without neurological symptoms or bladder symptoms. What comes to your mind first? Since there is no audience in front of me, I would ask each of one of you to ask yourself that when a man walks into or a woman walks into your room, how does the patient come to your room? Is the patient coming walking? Is the patient coming in a wheelchair, or is the patient on a trolley? So what comes to your mind first when a patient presents with these symptoms? So obviously, since we are discussing lumbar disc prolapse and degeneration, and we are excluding other causes here, and this is the commonest problem that as clinicians we see, you would think of this patient has a lumbar disc or a stenosis with a disc prolapse or something like that. And so what should you start with? So you keep answering yourself as to what we do start it. When I said that you should see how he comes into your room. Almost half the diagnosis is done when he comes into your room walking, if he's able to walk, whether he's got a sciatic scoliosis, whether he's bent forward, whether he's limping, whether he has a foot drop, how is he keeping his posture, is he in severe pain. So history will more or less give you a big clue. And then when you ask him about his symptoms, you should, he will himself say he had a sudden jerk, or he had been having a back pain off and on for many years. He used to take rest and become all right. And then suddenly he did something heavy, and then he had a sudden snap, or he felt a click, or he felt a sound, and then he had severe pain, and he was, for a few minutes, he was unable to move. Then his friends moved him or something like that. He'll give you the story. And it is important for you at this moment of time to get a history of his bladder, whether he's got saddle anesthesia, because these are the things you are looking at, whether he has weakness and how was it triggered, as I said. So, and at the same time, a lot of patients present to you with an acute symptom, so they forget their other symptoms, because these other symptoms which are the red flags. For example, a patient has got a tuberculosis with an epidural abscess, or a diabetic who had a procedure and got an epidural abscess. These patients would have associated symptoms which they may not link to this acute problem. So that also you need to take history of. So that is very important, because a lot of time I find in the OPDs that immediately he says, okay, you've got back pain, leg pain, you have an MRI, show me the MRI. So this history gets lost, and a lot of times you miss the diagnosis. Also important to ask him for a recent history of hospitalization or any surgery, and comorbidity, of course, is important, because we have a large comorbid population of patients with other diseases as such. So undress him. It's easy if it's male to undress. If it's female, at least you can see how they are standing and whether they have any deformity, they are stooped or not, and if they have spasm. So if a male person is there, let him get, you should get him to lift his shirt up and just see the examine, bend forward, how much can he do, and things like that. I think because of lack of time, I would not go into details, but it's very easy. This is a very easy chart that when you keep it in your mind that for L4, you can do an extension of quadriceps, dorsiflexion of foot is for L5, and plantar flexion of great toe and walking on toes is for S1. And the way I do is I see them walking into my clinic, then I ask them to stand on their tiptoes, the S1 is all right. Then I ask them to stand on the heels, the L3, 4 is all right. Then I ask them to do a Trendelenburg test and see if there is a dip or not, and the L5 is all right. Then I ask them to sit down, squat and get up, and then I know that the knee is all right. And then I ask them to sit cross-legged, I know the hip is all right. After doing this, then I get them to lie on the bed. I make sure that they don't have an hamstring spasm, so I bend the knee first and then do an SLR, and then do the bowstring test. Then you can do the femoral stretch, the hip examination, the knee examination. Feel the pulses always. It's very important to feel the pulses. You can ask you extra questions, any doubts while you're doing this examination. Feel for tenderness of the SI joints. Sometimes inflammatory arthropathy can also present with a small disc, similarly, which you may miss. So it's always important to do the Faber's test, and make sure that you have examined the hip, knee, ankle, and the pulses. So after you've heard the patient story well, you must make a provisional diagnosis in your mind. Just as you finish an operation, you should go up to the X-ray, the MRI, and ask yourself, have I done the right thing? Could I have done better? Or did I do anything wrong? And how will I tackle this next time? Similarly, as soon as you see a patient that take his history, I make a small note of my provisional diagnosis before I ask him, have you got any investigations? Have you been referred? Have you been taking treatment anywhere? Before that, you make it a habit of making a provisional diagnosis. And even if you're wrong, whether you made a diagnosis of L4-5 versus L5-S1, it doesn't matter. But you get into the habit. And then emotionally also assess the patient. So you assessed all the other systems. So most likely, if you have a lumbar disc prolapse in a normal 40 to 45-year-old person, I immediately don't start and do any investigations. I would initially start them with a conservative management. If I'm pretty sure in my mind that this is an acute episode, give them rest, non-steroidal analgesics, muscle relaxant, opioids, some gabapentinoid medication. Sometimes, very rarely, if I have a fresh MRI and as I see that he has a compressed canal, then I may give him a short course of steroids for 3-4 days and advise him physiotherapy. If they don't resolve, then I would call them mostly after 10 days. So I give them, ask them to buy a strip of each medicine. So one strip usually have 10 medicines, so the 10 tablets. So after 10 days, if they are not better, I would investigate them. Now, obviously, MRI is the gold standard, because MRI helps you in diagnosing more or less everything in the spine. And of course, you must have a basic X-ray, because sometimes sacroiliitis and other things may be missed. And you may be looking at an MR picture of a disc prolapse. An MR screening of the whole spine is a must. So always ask for an MR screening of your whole spine. While the commonest cause is a disc prolapse, I'm already finished 8 minutes. While a commonest cause is a disc prolapse, a differential diagnosis is a must. And that is very important to keep in mind. So you have lower lumbar disc, which are the commonest, that is L4-5 and L5-S1, and you have high lumbar disc. They behave slightly different. They don't have the typical radiculopathy pattern. They may have a mixed pain pattern. They may have pain in both the legs. L4, L5, and L5-S1 disc prolapse have a typical radiculopathy pattern on one leg. However, higher lumbar discs are more dangerous, and a high index of suspicion of an impending cauda should be kept in mind. And then you have the conus and cauda tumors. Other things, patients may also have a lumbar canal stenosis or facet cyst or various combination of stenosis or subluxation, which may present in acute phase. That was also important. As I said earlier, spondylodiscitis, tuberculosis, or epidural abscess is also important. Inflammatory arthropathy or referred joint pain is important. Osteoporotic fractures, METs, and intradural pathology also needs to be kept in mind when you're examining them. Sometimes I have seen a patient has a discectomy done for a peroneal neuropathy. Recently, I got a patient from Dubai who had symptoms of a typical that he was, while he was driving, he used to keep his leg outside, and then his legs used get numb and had a foot drop. He was a physiotherapist, and he had a disc prolapse at L4-5. So he came to me for surgery. When I got an EMG, he had peroneal neuropathy because his fibular head was a little odd. And so these things also sometimes can take you off balance. So piriformis syndrome and all this should be kept in mind. Hip pathology, never forget to check the pulses, and the psychological mental status of the person is to be kept. So Abhishek has already said that most of the disc prolapse are treated conservatively, even if they are large in size. So size of the disc prolapse doesn't matter. And it is very important to take a total picture before offering them surgery. So most disc prolapse are treated conservatively. And if you do MRI in a lot of them, they would resolve. Though Abhishek did say that some percentage you will find the bulge presenting. So the ones which have large annular bulge or a small bulge, they may persist, but large protrusions and sequestrations normally absorb. So it's all, though it's a common problem, most of them are treated conservatively. The only real indication for surgery is cauda equina, progressive motor loss, or intractable pain. And a word or two of cauda equina is that there must be bladder or bowel dysfunction, reduced sensation in the saddle area, sexual dysfunction. And back pain and leg pain may have come and gone. So that also is important to keep in mind. They may not always have the severe back pain or leg pain, because by the time they have cauda equina syndrome, they may have lost their leg pain. The conus medullaris syndrome should be also kept in mind, because you may confuse. This is a upper motor lesion and cauda equina is a lower motor lesion. So that differentiation should also be there. So one more point here is that there are 3 types of cauda equina. One which is symptomatic, which is the red flag. And if you see below, I have put white flags, because when you operate on them in these white flags, the outcome is poor. And have a large series of these cauda equinas when they really are not happy because their bowel, bladder, and sexual function doesn't come. So you must have a high index of suspicion. And a good thing to do is also do a residual urine or ultrasound of their bladder, so that you know that can correlate with your cauda equina symptoms. So this patient had an emergency surgery, and because he had perianal sensation decreased and bladder symptoms with retention, but they don't do so well. So urodynamic studies can sometimes help you to tilt the balance. If you think that this patient would really need a surgery and you want to convince him, look, your residual urine is more than 100 ml, so, or 400 ml or 500 ml, so you should do. Microdiscectomy remains the gold standard, and it gives a good result. Now we have a lot of endoscopic surgeons also in our panel, and they vouch that that is as good as the microdiscectomy, but at the moment we'll still follow microdiscectomy. So the take-home message is history and clinical examination is most important. X-rays, bloods, MRI required to confirm diagnosis. Not all black disc in MRI are cause of low back pain. Asymptomatic disc prolapse in MRI is around 5 to 20% under 50 years. So all disc prolapse are not symptomatic also. That also is important. A clinical scenario has to be there. Most are treated conservatively. As Dr. Chabra, who follows behind me, he has the largest series of conservative disc prolapse, and he almost treats all of them conservatively unless they have the real 3 indications for surgery. And cauda equina is a surgical emergency, and this you should have a high index of suspicion. Surgery is safe and cost effective in properly selected patients. Thank you.
Thank you, sir. Thanks for
Thanks,
that wonderful
Guru.
talk.
How do I stop share now?
Yes. Thank you. Thank you very much. We'll take the questions in the end. And now I would invite one more past president of Association of Spine Surgeons of India, Dr. Harvinder Singh Chabra, sir. And he has championed this non-operative management of degenerative conditions in spine. And let's hear what is the myth and fact from the pioneer himself. I welcome you, sir.
Thank you, Guru, for the kind introduction. You can see my screen, Guru?
Yes, sir.
I think the stage has been set for my talk by the previous 2 talks, and thanks to Dr. Shankar Acharya, who has set the stage very appropriately. So just reinforcing what Shankar said, we have to treat the symptoms and not the radiological findings. So many of the MRI findings may be there without any symptoms, and we don't need to treat them. And most of the literature documents that in the absence of cauda equina syndrome, the initial treatment is non-operative, and most of them would respond to a good conservative management. And we will briefly discuss what the conservative management is and go step by step into this. The membrane stabilization agents have been found to be quite effective in management of the radicular pain, which may be either due to a disc prolapse or due to a lumbar spinal stenosis. And you have to, studies show that you have to gradually increase the dose in order to get optimal benefit. And you can go up to the maximum dose of the neurotropics per se. And so gabapentin has been one drug which has shown good results, as has pregabalin. And amitriptyline is another medication that is there in our armamentarium, and so is duloxetine. And but just note that each of them, like duloxetine, we can go up to 120 milligram per day. And similarly, gabapentin, we can go up to 1800, some say even up to 2400. And there is in the literature use up to 3600 milligram also. And similarly, pregabalin, we can build up to 600 milligram as such. And then there is literature that if you use a combination, one is an escalation protocol gradually, where you increase the dose, because many of these medications would have may cause drowsiness and giddiness. So you gradually build up on them. But as you combine them, you have more optimal results. And this is well documented in the literature per se. Also, the literature, there is literature that if you use oral or systemic corticosteroids, they also help in reducing the inflammation in the nerves. And so these could be combined in the treatment. So our conservative protocol, thanks Guru for pointing this out, we presented it in ESALS as well. So we generally start with pregabalin and build up the dose. But if people don't tolerate pregabalin, they have drowsiness and giddiness, we reduce the dose and supplement with oxcarbazepine. If they do not tolerate either of them, or if they do not respond, we sometimes switch to gabapentin also. If they do not have relief with pregabalin or pregabalin oxcarbazepine or with gabapentin, then we add duloxetine, starting with 20 milligram, and we build up to 120 milligram also. And if they still don't get relief, we use amitriptyline also. We could go up to 75 milligrams. And if there is still no relief, or if the pain is acute, We can even add oral or intravenous methylprednisolone. That is our escalating protocol for neurotropics in management of disc prolapse. Now, other than the medications, we generally would ask them to build up on the exercises as the pain reduces, and we generally use general conditioning exercises, walks, treadmill, sports, aerobics, swimming. So they would gradually build up as the pain reduces. If the back stabilization exercises are not as important as per us in the general in building up of the aerobic muscles, that's also well documented in the literature, but they can complement this with that. And we generally encourage them to remain as active as possible. Bed rest, we generally ask them to avoid except if the pain is unbearable, and then to for a maximum of a couple of days. So there is conflicting evidence for the role of the bed rest for lumbar disc herniation, but the Cochrane review also mentions that people who stay active do better than those who go in for bed rest. Manipulation is another tool in the armamentarium for the therapists, but they need to be trained well to be using it. And deep heat generally gives short-term relief. We generally do not use traction any longer because in our experience, sometimes it can increase pain. But some people who are refractory to conservative treatment, if they try traction, we ask them to do so under supervision. And if the pain increases while on traction, they should stop it immediately. Of course, we also advise them that they could get electrical therapy done, TENS therapy for leg pain, shortwave diathermy or microwave diathermy, and interferential therapy for back pain. That they do. So now this has been our multimodal conservative therapy where we combine medications, exercises, posture care, physical modalities, counter irritants. And if they do not respond, we generally would put them through offer transforaminal epidural steroid injections, a maximum of 3 doses in a year. And if they still don't respond, we would go in for a surgery. Of course, always the assumption is that there are no red flags. If there are red flags, then we have to go straight away for a surgery. And there is evidence that epidural steroids can help in people who do not get relief with good conservative protocol. And 3 epidural steroids generally reduce the chances of surgery by as much as 60% in those who have not responded to a conservative treatment. Some use steroids, others use ozone when they use transforaminal epidural steroid injections. But since the steroids are more time tested, we generally resort to it. Of course, this has been mentioned there. If there is increasing neurological deficit or significant neurological deficit or bladder and bowel involvement or failure of a good conservative trial, then surgery is the next, is the choice, is what we need to resort to. We try to compare our outcomes with various other trials and found that our protocol compares well with many of the other long-term studies which were done with good relief in outcomes, good outcomes and good relief in the pain when we did a comparative study. And the recurrence rate was 15% in our series, but they again would improve with a good conservative treatment. And now around 69% of our patients who had been advised surgery elsewhere responded to a good conservative protocol that we implemented again. And in our study of 405 patients of disc prolapse, 5.4% eventually required surgery. So the carry-home message, most cases of PIVD respond to a good conservative treatment, and this is a fact based on evidence and based on experience. The only absolute indication for surgery is the Cauda-Equina syndrome, and for those who fail a conservative treatment or have a progressive neurological deficit, discectomy alone gives a good outcome. So thanks for your patience. We have tried to outline how we follow conservative treatment, which is based on evidence and also on experience. Thank you very much. Over to you, Guru.
Thank you, sir. Again, that's a wonderful talk. After we know now what is the conservative treatment and surgical indications, we have another doyen of spine surgery, Dr. Arvind Kulkarni from Mumbai. So he's going to, and he is one of the masters of tubular surgeries. So he's going to show us the video on tubular discectomy. And I also would request Dr. Arvind to go slow because he has a time of Dr. Sanjay Rajan also. So you can in between tell us the tips and tricks also, where and what. Thank you. Over to you, Dr. Arvind.
Yeah, thank you, Guru, for this invitation. So I'll share my screen here. Sorry. Just a second.
Yeah.
Guru, we can take some questions.
Yeah, that's what Meanwhile, Dr. Abhishek, the delegate wants to know what is the difference, how do you differentiate between mechanical back pain and pain due to PIVD? Dr. Abhishek? I think he's not there. Chabra sir, can you take that question? Okay, anyway, we'll continue with Dr. Arvind's talk. His screen we can see. We'll take up the question.
Can you see the screen now?
Yes, Arvind.
I thank the Delhi Spine Society and Guru Raj for this invitation. So this is a case illustration. I'll directly go to this particular case. This is a significant disc herniation. This patient is 40 years old. He's a desk job worker. He has severe shooting pain on the right side of his leg. He's along the L5 dermatome. It is associated with paresthesia. He's not able to walk. He has very mild weakness in his toes and ankle, dorsiflexors. He has tried all kinds of conservative treatment. The pain has been there for more than 3 months now. He's had a root block with no significant relief. So he wants to get rid of this pain. So we went ahead with this surgery called tubular discectomy. So it is basically a microdiscectomy as was described by Dr. Shankar Acharya. Microdiscectomy is a gold standard procedure for this particular situation diagnosis. And the same microdiscectomy, when done through this particular tube, it is called a tubular discectomy. So that is what my specialty is. So in a standard microdiscectomy, what happens is you generally take a midline or slightly paramedian incision on the side of herniation. You cut the skin, cut the fascia, go through all the layers. You reflect the paraspinal muscles which are stuck to the spinous process and the lamina. You reflect them and put your retractors It could be, bilateral exposure or unilateral exposure most commonly. And there are various kind of retractors which retract only on one side. And once that happens, the microscope comes into view, and then you go ahead with this particular surgery. But the length of the incision varies when you do a standard microdiscectomy, depending upon the size of the patient. You need to go deeper and deeper, so you need to do a longer and longer. You need to take a longer and longer incision. So in tubular discectomy, all this is bypassed. So you don't have to cut, and reflect the muscles. We take this potential space. It is an intermuscular space between the muscle fibers through which a series of dilators are passed one on top of the other, and these dilators helping developing a port between the muscle fibers. The port that is inserted varies in length depending upon the depth of the patient. So it could range anywhere from 4 to 10 centimeters, and it also varies in terms of the diameter of the tube. So initially in practice, I would suggest one to start with a 18 mm tube, which is quite comfortable to start with. And over a period of time, one can graduate to a smaller tube. Right now, I use a 14 mm diameter tube for most of these discectomies. So that comes with experience. The advantage of the tube is, so unlike in microdiscectomy, so it walls off all the soft tissue, the tube. So there's very less, seepage of blood into the field. So you get a very avascular field when you're operating. And it also helps as a good navigation instrument. Suppose the disc is migrated up or disc is migrated down, or, disc is, if it is an extradural disc, so the tube goes exactly in the direction of that particular disc. So your goal, you're not lost when you're operating, because the tube itself will take you where the herniation is. So as in any disc surgery, localization is very, very important. It is a crime to do a wrong level surgery, and correct localization is more than half the work done. Once you're on your spot, you know what to do. The entry point is about a centimeter away from the midline in L4-5 and L5-S1, and slightly more medial if it is at a higher level. So these parameters have to be customized. What one should check on AP image is that the spine is not rotated. That is very, very important. And what one should check in the lateral image is that, so initially you start with a needle, 20 number spinal needle, which helps not only localizing but also in giving preemptive analgesia. So this particular needle has to bisect the disc space in a standard shoulder disc herniation where there is no much migration. So this is very important, because the tube will follow that particular direction. Again, as I pointed out earlier, the parameters depend on the patient, depend on the level at which you're operating. The laminar shorter, smaller, higher up. The facets are close by, higher up, while at L4-5, L5 are wide apart. So this has to be customized to the patient. So I generally, the first instrument that one uses is a guide wire. Personal experience and various articles on this have been mentioned. Wherein as soon as the dilator goes in, there's nothing. It's a very thin, narrow guide wire. It can poke the phlegm and get into the canal, and you already can have a CSF leak before you started the case. So most of us don't use the guide wire. We directly use the first dilator. So what generally is done is, as I said, we use a 20 number spinal needle. It goes just short of the lamina, and this is checked in the lateral. And I inject 15 to 20 cc of diluted sensocaine. So it does two things. One is it allows a bloodless dilatation because it creates a tamponade effect. Second is it provides preemptive analgesia before you start surgery. So once that is done, centered over it, I'll take an incision. So if I'm using an 18 mm tube, the incision will be about 2 centimeters. So I cut the skin, cut the fascia, and start inserting these dilators. So these dilators are inserted one on top of the other. They are of increasing diameters, and these dilators have markings on them which will guide the depth of tube that you're going to use, the port that you're going to use. It is usually suggested to use a slightly longer tube, one that is more. So suppose it is flush 5 mm mentioned here at the level of the skin. Use a 6 because it keeps coming out. And so this is a 18 mm diameter tube, and the depth is 6 centimeters. So that is what is designated here. So this is how the tube goes in. It lands in the valley between the spinous process and the facet. So these, it is very important to not to traumatize soft tissues. You have to cut the skin, cut the fascia. Many people don't cut the fascia, and that causes a lot of trauma. So go take clean incisions, go through the fascia, and then start dilating the tissues. If so, see, once you enter a wrong plane, so once you select a wrong disc level, it's very difficult to move to the next level. It causes a lot of trauma, and in inexperienced hands, it becomes very miserable. So it's very important that your localization is perfect. Now, there is a misnomer. This particular surgery for a long time was called microendoscopic. The only reason being, so initially the first set of matrix, that matrix 1, came with tubular dilators and the tube which was connected to an endoscope. Then came matrix 2, which is what I'm talking about, wherein the tube is used with the help of the microscope for visualization and magnification. So they started using this term called microendoscopic. This is a term which I used to use long back, but I've given it up. So it's basically a tubular microdiscectomy. So this patient which I showed you, it is this patient's video. So currently, as you see, you'll see the tube already in there, landing on the lamina. So it's a right-sided L4-5 discectomy. The right is the cranial side, the left is the caudal side. Superiorly, at the top is the medial side, and my hands are on the lateral side. So this is the lamina, and this is the flavum. This is what one should visualize once the tube goes down in a straightforward discectomy. So operating under a good microscope is as good as operating under sunlight. It's so bright here. So using a cautery, you expose the lamina. So I use a 4 mm cutting burr to drill the inferior margin of the lamina and some part of the medial facet. So the burr acts as it helps in thinning the cortex as well as acts as an hemostat. So as you burr, it seals off all the bleeding from the cancellous bone. Then there is this cup curate, which helps in separating the ligamentum flavum from the lamina, inferior border of the lamina. So rest of it is all basically a microdiscectomy. So this is a flavum. So how do you manage bleeding from the bony surfaces? It's very important that all bleeding spots are closed as you go down, because it's a very limited area in which you're operating and you don't want a bloody field. So I create a cleavage in the flavum with a pen field, more towards the center, because there is good amount of fat between the flavum and the dural sac towards the center. and then make sure that the dura is not stuck to the flavum, especially in this case because it's a very large herniation. So make your first bite towards the center where there's more potential space. And then once you're sure about the planes, then go laterally. So now I'm going laterally. So this nerve hook is a very important instrument. It's a very strategic instrument. It gets a higher place than any other instrument, when I do a discectomy surgery. So one can see the lateral margin of the root plus this disc. That was a fragment. So make sure that there are no other fragments compressing the root. You know from the MRI that there's no fragment which is migrated up or down. So you need to just explore at the level of the disc. So one has an option of spraying some steroid on top of it. And now you close the fascia and the skin. Skin is closed with 30 monocryl. So it hardly leaves a scar. Thank you.
Thank you. Thank you, Dr. Arvind. That was a wonderful talk. So we'll go to the next talk by Dr. Neeraj Gupta. Dr. Neeraj Gupta is a senior consultant at Indian Spinal Injury Center. He will be talking on post-operative discitis. Over to you, Dr. Neeraj.
Can you see my screen, Guru?
Yes, you have to make it full screen.
Yeah. So my screen is visible? Full screen?
Yes. You can go ahead.
Okay. Thanks, Delhi Spine Society, for this opportunity. Thanks, Dr. Gloraj. So today I'll be speaking upon post-op discitis management strategies. So this MRI, which we routinely see in our practice, patient is having L5S1 disc prolapse, and once after the failed conservative management, we give the option of surgery to the patients, which could be open discectomy or microscopic or endoscopic or tubular discectomies. But once the discectomy is done and the patient is relieved of the pre-op symptoms, and the patient comes with patient gives history of excruciating back pain, which is more than the ordinary back pain, the post-op back pain, and more of instability back pain, and gives this type of, and we can repeat the MRI and we see the MRI, this type of MRI is seen, we should always suspect an infection. Then if we get the CT done, you can always see there are end plate erosions are there, and 12 weeks post-op, we could see sclerosis. So today we are discussing on this topic that which is post-operative discitis. It was first described as clinical entity by Turnbull. It can follow any sort of invasive spinal procedures, but the incidence of post-procedural discitis is relatively common. We routinely don't see after our cases, but we should be very cautious and we should be very much like if the patient comes with severe back pain, we should always suspect, and we should have a very high index of suspicion if the patient is having severe back pain. But the cases has been increasing each year, reflecting the increasing number of spine surgeries performed, and it is frequently affecting the elderly and the immunocompromised patients. So post-procedural discitis represents 30% of all cases of pyogenic discitis, but incidence of post-procedural discitis after any type of spinal procedure is only 0.26 to 4%. That's why I said it's not very common to see in our practice. So natural history, the discitis usually it is mild, self-limiting, and resolves spontaneously by conservative management. But in some cases, patient may have fulminating sepsis with abscess formation, with discharging sinuses also, and which need to be reoperated. Pathogenesis is like this. Initially, there is inoculation of bacteria, which may be because of the poor sterile measures during surgery, or sometimes maybe due to a hematoma collection, maybe because of the end plate fractures. Anything which can cause bacterial inoculation or nidus of bacteria can be there. Slowly, the bacteria proportionately bacterial growth increases, followed by the granulation tissues. Once there is increased vascularity in the end plates and granulation tissue is there, patient present with severe back pain. And as the granulation tissue increases and vascularity increases on CT, we can see there are end plate erosions can be seen, and it later, say at 6 weeks later, it is changed into opposition new bone is formation after as a reactive measure, as a reactive response of the body to the infection, and there is sclerosis is there on we can see on the CT. So types, it could be septic form, which is caused by infectious agent, or it could be aseptic form resulting from an inflammatory reaction, or maybe because of the less virulent low-grade infection. Infectious agents are most commonly Staph aureus and anaerobic organisms. Less common are Streptococcus, E. coli, Pseudomonas, or Mycobacterium tuberculosis. Fungus is also a rare organism. As I told, there should be high index of suspicion. There are no clear-cut signs which we can say, okay, this is because this pain is there, it is definitely it's an infection. So there is no clear-cut signs. Definitive signs are not there for infection. So, but therefore there should be high index of suspicion should be there. And in many cases, there may be a delay in diagnosis because of the frequent occurrence of back pain after spinal surgery. So we'll be confused with the post-operative back pain. So diagnosis can be established in a timely fashion based upon the history, which is very important. If the patient gives unproportionate, if we get the history of unproportionate back pain, we should always be we should have a high index of suspicion. Then the physical examination, patient is having instability back pain. Laboratory studies should be done. With the most common are ESR, CRP, and blood cultures. And the imaging studies are we get the routine X-rays, MRI, CT, and radionuclide scanning. Clinical presentation, as I told initially, patient once the surgery is done, if the patient get relieved of his pre-operative symptoms, but after 3 to 4 weeks or 4 to 6 weeks, patient present with gradual increase of back pain to mild to severe, and patient may have that much severe pain, and patient may confuse it with the initial clinical picture, and even clinician can be confused whether it's a recurrent disc or something else is happening. So because the pain is increased that much. So the back pain is out of proportion. Referred pain could be there to the buttocks, thighs, legs, groin, perineum. And sometimes only the referred pain could be there. There may not be any back pain. So we should be very vigilant in such cases. The most common time frame for the development of increasing back pain is 1 to 4 weeks in the post-operative period. Fever is usually not there, or if present could be only mild. In rare cases, there is fatigue or malaise. And physical findings also, usually you don't find any major physical findings. There is no wound dehiscence is usually not there, and the signs of inflammation are also not there in the usually in the most of the cases. But the laboratory markers are very important. WBC is unreliable; it's usually only slightly elevated. But ESR and CRP are very important. ESR, elevated ESR is always there. Whenever there is elevated ESR, there should be high clinical suspicion. But it's not a very because ESR values are irregular and remain elevated in 33% of after 6 weeks of surgery. So it's not a very definitive marker. But CRP is having high sensitivity and specificity of 65 to 100%, and usually CRP returns to normal within 14 days. But if the CRP is continuously increasing, CRP is more than 50, 60, or in the range of 100, we should always suspect infection. And the combination of ESR and CRP is always best for the treatment prognosis, to judge the treatment prognosis. Then imaging, MRI is the best and the modality. MRI is superior to the gallium and the bone scan. X-rays should always be done, but X-rays are not sensitive and usually lag behind the physical examination findings and laboratory markers. It takes 4 to 6 weeks for the X-ray changes to come, and the X-ray changes are usually loss of the disc space is there. There is blurring or clouding of the vertebral end plates are there. CT is also a very good marker if we are suspecting infection, and on MRI we are suspecting infection. We should always get the CT done. In the early periods, we could see there is end plate blurring could be there. We could see erosions in the vertebra in the CT. Then the gallium scan and technetium scan are also the imaging markers. Then tissue diagnosis is the best thing which we have to do for the definitive diagnosis and management. Tissue diagnosis is very important. Tissue diagnosis could be done either by needle aspiration, transradical biopsy, endoscopic biopsy, or an open biopsy. So tissue diagnosis is the best. Once we get the tissue, we should send it for conventional culture and sensitivity or the molecular diagnostic methods. In molecular diagnostic methods, we have PCR. We all know we are routinely doing PCR tests. Then there is another one is the MRSA specific PCR is there, in which which is a 16S ribosomal RNA gene-based universal PCR. It's a rapid test, and identification of MRSA infection can be there. We can identify the MRSA with this 16S ribosomal RNA gene-based universal PCR. Coming to the treatment, prevention is the best. You should always use appropriate antibiotics, and before antibiotics, you should have proper sterile measures to be taken. Then the draping of the C-arm and all the draping of the patient should be proper. Then we should always a patient having comorbidities, elderly patient, immunocompromised patient should be properly counseled since they are having high risk of infection. So all these things should be considered preoperatively. But in the steps of once the we have diagnosed it as discitis, then the steps of management are first we should get the baseline laboratory studies which include WBC, ESR, and CRP. Blood cultures should be sent, needle aspiration for the tissue diagnosis. And when the organism is determined, so there are two types of scenarios. Once in one scenario we have got the diagnosis, we have got the tissue diagnosis, and in the second scenario we have not got any tissue diagnosis. So when an organism is determined, sensitive specific IV antibiotics followed by appropriate oral antibiotics can be given. The exact period of antibiotic usage is usually 6 weeks IV and 6 weeks oral. And if the organism is not determined, broad spectrum antibiotics with anti-staphylococcus coverage are recommended. And after 6 weeks of antibiotic and orthotic management, if constitutional symptoms progress, or if there is continuous back pain or the laboratory markers continuously going to worsen, ESR CRP is not settling, we can go for open procedure. So there is no fixed protocol for dealing infection. It all depends upon the patient, how the patient is responding. If after giving IV antibiotics and giving rest to the patient is responding well, we can continue with the conservative management. But if there is pain is progressively increasing, or there are neurological symptoms, or there is we can see even after giving antibiotics there is the laboratory markers are continuously worsening, we can go for open debridement and infusion. The aim of the surgery is to remove the infected material, debride all the necrotic infected bone, and stabilize and fusion with the bone graft. And usually we do TLIF in such cases, and this is how it is done. The take-home message is post-op discitis is a rare phenomenon. It is on the rise with increase in spinal procedures and elderly population. Conservative treatment is IV antibiotics is the treatment of choice, but surgical treatment reserved for failed conservative treatment. Thank you.
Neeraj, dealing with one of the most difficult problems after disc surgery. Now I invite again one of the stalwarts of spine surgery, Dr. Kalidatta Das, who is a director and a senior consultant at Indian Spine Injury Center. Sir is going to talk on recurrent disc, which is again enigma, whether it is a recurrent disc or it is a residual disc. And over to you, Dr. Das. Can't hear you. Dr. Das, I think you need to unmute yourself. We can see your screen moving. Can't see.
Is it okay now?
It's fine. I think you need to go back to first slide, sir.
Yeah.
Yeah. Yeah.
So thank you for your kind introduction, and sorry for this little technical glitch. So now the basic question is, when do we say it is a residual disc and when do we say it's a recurrent disc? So if there is the same disc in after a period of well-being, that is after the definitive surgery of the index level of a disc, the period of no pain or symptomless period is there for more than 6 weeks, the patient again complains of the same kind of symptoms, we call it a recurrent disc. A residual disc is when there is no period of well-being after the index surgery. So as told by the earlier speakers, disc is one of the predominant scenes which is seen in the OPD, and it is financially burdening. So when does this recurrent disc herniation take place? We need to understand how it happens or why it happens and if it is under our control. So if there is an incomplete removal of the disc, if there is spinal stability, if there are modic changes, and there could be also factors which is related to the patient. So we have modifiable factors like smoking. In smokers, there is a lot of chronic coughing taking place. So most of the times, the annulus which has not healed after a discectomy, the disc again tends to keep coming out. We have obesity. There is no direct indication or correlation between the obesity and a recurrent disc, but it has been seen that in obese patient where the BMI is more than 30, they are 12 times more susceptible to a recurrent herniation. In diabetes, we all know that there is problems of wound healing. Most of the time, the recurrent disc is because the annulus which is torn and through which the disc has come out is unable to undergo fibrosis and sealing the defect, leading to a recurrent disc once again. We also need to take the parameters which has the biomechanical factors in which X-ray plays a great and important role. As routine the spine surgeons do a flexion and extension X-ray, the picture on the right demonstrates if there is an angular instability. Most of the time in flexion, when the posterior margin opens up, you can suspect that there could be a deficient PLL or the annulus is torn, wherein it can be taken more than 11 degrees as a instability. So just doing a discectomy can give you a thought whether you need to do something more than that or to follow up these patients. Now, it is found that in the primary discectomy, there has always been a controversy how much to remove and how much not to remove. Most of the people say that flavectomy is enough, whereas how much of discectomy fragment needs to be removed is a question. Mostly large discs need a lot of removal. A lot of surgeons also do a lavage and wash for any disc which is free floating to come out. Now, what are the radiological predictors which may say that yes, this is the condition or these are the candidates in which there could be a recurrent disc herniation? If there is the disc height index which is compared to the disc above and disc below, if not L5S1, if there are any modic changes, and if there are increased sagittal range of movement in the pre-op X-ray. These are indicators wherein there might be a chance of a recurrent disc herniation. Yes, it is controversial. Now, repeated surgery is the current standard for the recurrent disc herniation in the lumbar disc. So what are the options do we have in a recurrent disc herniation? We have, like earlier speakers, reiterated the path of conservative treatment once again. We have done epidural injections, after which, when we label the patient as a failed condition and we need to operate him, we need to do a discectomy, whether it is conventional or minimal invasive, based on the factors, surgeon preference, presenting symptoms, axial low back pain, and radiographic inference of instability or deformity. We need to think whether we need to do ideally a discectomy or fuse this patient, on which we will delve a little later. So one of the dreaded complications which is commonly associated with a resurgery in a disc is a dural tear or an injury. The overall reoperation rates is from 5.2 to 19%. That is what the literature quotes. Reoperation rates is 0.5, which increases at 15 years, it increases to 2.8%. We have a lot of literature by different authorities and different surgeons of revision discectomy and what is their incidences. So many authors advocate the repeat discectomies can be used as an effective treatment for recurrent disc. This is the first time recurrence which is associated with radicular symptoms unless the patient has an indication otherwise for limited or instrumented fusion. Now, where does fusion come into being? There are parameters. If the discectomy previously done has a repetition of more than 2 episodes, which in there is a third time, where are there biomechanical factors which says that yes, there is an associated instabilities. These are the conditions where we might think of fusion. So significant deformity, instability, and associated axial low back pain are indications where a fusion can be thought about. Now, we have a paper from Dower et al. Where significant improvements were noted in back pain scores in patients undergoing fusion. There can be associated literature which can go against or for whatever you want to find, but the thumb rule is in the first case of a recurrent disc, we need to do a discectomy unless and otherwise there is a lot of adhesions and we are not able to differentiate between the layers and the neural structures. Just a small case illustration of a recurrent disc herniation which underwent fusion. Now, if you compare a P-leaf and a T-leaf, the T-leaf is a much safer procedure because you are retracting the neural structures less. You're growing from the side. You take the facets out because it is a virgin area. You come to the disc proper, wherein you are not handling the neural structures which may or may not be fibrosed or adhered to each other. So there are no clear-cut consensus regarding the number of repetitions or repeat herniation which requires consideration for instrumented fusion at the affected level. So in the absence of low back pain or radiographic instability, most common surgical intervention for the first time recurrence is a repeat discectomy. But with each subsequent surgery, the chances of introducing or worsening segmental lumbar instability increases. As a repeat procedure, wherein facetectomies would be required, we are thinking of a fusion. So the threshold to incorporate instrumented fusion decreases with the increase of number of repeated herniation. So this is the thumb rule wherein difference in the surgical treatment of recurrent disc herniation is there among the spine surgeons. We do have minimal invasive endoscopic technique. It depends upon the surgeon's acumen and his training. It is feasible for revision discectomy and can provide an effective alternative to conventional approaches. We have a lot of literature review which is between open and minimal invasive. However, there is a limited high-quality evidence to support the use of microendoscopic discectomies over microdiscectomies with surgeon's preference and comfort, often dictating the operative technique used for a recurrent disc herniation. So what are the outcomes that we see in recurrence? We do not have our own registry, but a large analysis of 13,000 odd patients in the Swedish National Spine Registry found a 79% patient satisfaction after the initial discectomy versus a 58%, wherein it differs with our own findings. We do not have a spine surgeon a flow chart, but the World Neurosurgical Society has a flow chart of recurrent disc herniation, whether it is ipsilateral or contralateral. If it is contralateral, it is virgin, it goes directly to a discectomy alone. If it is ipsilateral, whether there is back pain, modic changes, additional stenosis, then it undergoes fusion. The only in between is if the ipsilateral, wherein the disc height is decreased, only sciatic pain is there. It is after a long duration of first surgery, and it is only the second recurrence. You can think of a discectomy alone. So, in summary, or the take-home message for young surgeons would be that to evaluate the patient factors, modible factors, and the radiology in a recurrent disc herniation, you must assess the patient and counsel the patient for neural injury or a dural tear. For those with recurrent lumbar disc herniation who have failed non-operative management, a repeated discectomy is advised. I thank and close my talk. Thank you.
Thank you, sir. Now the time for questions. We'll just continue with the first questions which we had taken. What is the difference between mechanical back pain and organic back pain? Dr. Abhishek, can you just show us that slide which you have put it on the group?
So I think you can see my slides now.
Yeah.
So the question is whether you are dealing with I think it was first lumbar. You asked me mechanical pain versus lumbar disc.
Yeah.
Anyway, so the main question is whether how you differentiate between mechanical and non-mechanical. Mechanical is something which is degenerative, and it is a slow, progressive cause of back pain. It can be because of many spinal structures which can cause mechanical back pain. Non-mechanical back pain is basically because of inflammatory response, either because of inflammation, because of autoimmune disorders. It can be because of infection. It can be because of neoplasia. It is not affected by movement. The mechanical back pain is usually when the patient starts moving, he has pain. In non-mechanical, it is usually a continuous kind of a pain. So there is no relationship with movement as such, if you see. Mechanical pain usually improves with rest, and the non-mechanical pain has no relationship with rest. Red flag signs are usually rarely present, and they are usually present in a non-mechanical case. I think the question you asked me was whether how you differentiate between lumbar disc and mechanical back pain. So the main symptom is that lumbar disc pain is basically pain which is centrally located and often radiating down the leg. Mechanical pain is basically kind of a referred pain. It is not moving down any reference point. It is usually like a sciatica and follows a dermatomal pattern, whereas mechanical pain rarely ever would follow any nerve root. It usually goes from the back, and it basically goes and localizes to the buttock. Usually the lumbar disc pain is usually sharp and burning like, whereas mechanical pain is usually dull, aching, sore. They are usually aggravating factors in a lumbar disc that it usually gets aggravated by sitting and bending forward, whereas mechanical back pain is usually seen more in morning day activity and usually gets aggravated as the day progresses. Usually, the lumbar disc pain usually would get relieved by lying down flat, and whereas mechanical back pain usually heat, rest would decrease their back pain. I think I may be able to answer your questions.
Thank you. That's a wonderful slides, Dr. Abhishek. And Dr. Arvind, are you here?
Yes.
Yes,
Yeah.
Dr. Arvind, can you just throw a light on disc in young patients? So somebody wants to know basically association between facet arthropathy and PIVD in young patients, but then you can just throw a light on how are they unique and how do you manage them?
So it is generally facet arthropathy and disc in young adults don't go together. Facet arthropathy is usually seen in the
Stages.
last stage of the Kirkcaldy-Willis cascade. So it is usually seen in elderly patients, very elderly patients, facet arthrosis and disc herniation, wherein and disc herniations are not very common in elderly patients. There is usually a stenotic lesion, and on top of that, there may be a hard disc protrusion, which can cause leg pain. So with regards to the young patients, the thing is, very young patients. So the disc, in terms of surgery, the disc is very turgid. It's very difficult to remove the disc. It's very sticky when you're operating. Compared to, especially in a contained disc, compared to a non-contained disc. That is one difference in surgery. With regards to the presentation, there's nothing much. It's like any other disc herniation, especially except that in young patients there's no associated stenosis.
Okay. Okay. Dr. Mahapatra, there's a question. How do you basically, I think Dr. Shankar covered it, but then can you just tell us in 2-3 lines, how do you select patients for surgery to avoid failed back surgery in disc patients? Dr. Bibu?
Yeah, Guru. Hi, it's very important questions and which we face on day-to-day life. The most important thing in the disc is to evaluate them properly and rule out the other differential diagnosis which can cause similar symptoms, especially if it is a young patient, we should rule out the inflammatory pathologies which can cause similar kind of symptoms and or any neural impingement syndromes. So that is one. If it's an adult, we should otherwise also rule out the other pathologies which can present in a similar fashion. But as having said that, most of the disc herniations, they do well with conservative management. And if we should always give a trial of conservative management if there is no red flag signs, as has been said by Dr. Shankar Acharya and Dr. Chabra. And we should give a fair trial of conservative treatment. And in case the conservative treatment in form of medication, physiotherapy fails, then we can try some uh, uh, treatment in form of spinal injections, which also a lot of patients do benefit from the injection. And still, it's a fair amount of trial for 3 months. Usually in the literature, they say that a 3 months trial is a fair amount of period to be given for conservative treatment. Still, the patient has symptoms, and the symptoms are affecting their activities of daily living or affecting their own work, can be suggested for surgical treatment.
So I would just want to add on to that. One important thing which you have to see is to avoid failed back surgeries for your disc patients is there should be a clinico-radiological match. So whenever you have a clinico-radiological mismatch, that is when you tend to have your failed back surgeries for disc. And whenever
that comes with a clinical examination. If
Yeah.
it's clinical examinations, if it is not correlating with the disc and the radiological parameters, I think we should wait and look for other causes of pain.
And whenever you do any surgeries for disc for back pain, then again you tend to have failed back surgeries. So these are the most two important factors. There's one very interesting question. If Dr. Shankar or Dr. Chabra sir is there, how do you nurse a patient with PIVD with pregnancy? So any experience?
I think Dr. Chabra would like to
Yeah.
answer it. He has a lot of experience in that.
If Dr. Chavra is not there, Dr. Shankar? Dr. Rupinder?
Yeah, I think the indication of the surgery remains the same, whether pregnancy is there or not. Because if there is a cardiac angina, there is a progressive neurological deficit. Probably the third indication, which is a excrutation pain, is a relative indication as pain perception is different in different people. So you can give some things. Only thing is the technique of doing a surgery probably varies. Most of the people would do it in a lateral position, and probably just because there's a cardiac angina and a pregnancy, I don't think we would do that. And apart from nursing, the change anesthetic techniques, anesthetic gases, all those things make a difference.
Okay. Dr. Arvind, do you have any special comment on disc with pregnancy?
Yeah, I've treated a couple of patients with pregnancy who had disc herniation, but this is all managed conservatively.
Okay.
With rest, medication.
What
fulfilling.
medications do? Usual question in pregnancy, the most important thing is about medication.
Yeah. I give them paracetamol 3 times daily.
Okay, and then rest, leave it for the natural healing, right?
Most of them will be. I mean, I just have experience of 2 patients, but in our other discussions also, what I've seen is once you counsel these ladies, they get pray from all kinds of sources till the kid is delivered. There's so much dedication towards delivering the kid. The rest of the things take a second, seat.
Definitely.
So they manage.
Okay. So
Guru, I have a question.
Yeah.
Just for discussion's sake, I'm asking can we use gabapentin or pregabalin in pregnancy? In second trimester. First trimester, usually it is contraindicated, but in second trimester, if the patient is having severe pain and we are avoiding surgery, and paracetamol, although can we give gabapentin, or are you guys giving gabapentin or not?
Neeraj, I don't think we have any literature evidence which can be given safely in this, even in second trimester. I think the best drug, what Arvind said, that is basically to give paracetamol, and the other anti-inflammatory, which is bit safer in pregnancy in second trimester, can be used a naproxen. Sometimes you can use it, but not regularly, and physiotherapy.
Basically, the crossing of gabapentinoids of the blood, basically placenta barrier, is not known, and the side effects which they cause in adults, like drowsiness and giddiness, whether that adversely affects the fetus, that is again not known. So I think right now the answer is no. You cannot give it till they deliver the baby, and even if they are breastfeeding, then still we don't know what is the effect of these drugs on the neonates. So again, it's no for breastfeeding and pregnant children.
Yeah, thing is, we don't have a literature evidence of not using it, but we don't have it even if it's safe or not. So that's why we are not able to give it.
So Abhishek has raised a pertinent point. We can try basically ultrasound guided epidural injections in these patients. So that's again a good point which he has raised. So I think
the only thing is, while epidural steroid, we have to protect the baby and with a good lead shield, and we can.
He's saying ultrasound guided.
Okay, ultrasound guided is much more better. I know if you don't doing ultrasound guided
in second and third trimester, you can do a normal root blocks also in these patients
by protecting the baby with a lead shield.
Yeah. Dr. Das, you wanted to say something?
No. I just
okay. Rupinder, Dr. Rupinder.
Just an addition to Neeraj's talk on discectomy, on infections.
Discitis,
Discitis, I think if it's a florid discitis, and the best thing, if it's multi-level disc or decompression, what I use in most of the cases, if there is an old dural tear, I use a pulse lavage to wash up the tissues at times when it is little late. And probably the vac is the best thing to get over the infection faster with a very good results, provided there is no CSF leak.
Okay. So I think we are running out of time also. We are exactly 9:35 now. I think questions are also over. But then one last question for the president, but you need not answer it. How to do scoliosis surgery? That we will cover.
Yes, we have a
That we
session
will
on
cover
that.
in
We definitely will
subsequent,
deal with it.
yeah, subsequent topics. So that's a one whole webinar. So I thank once again.
Scoliosis you can treat. Scoliosis you can treat with discectomy. Discectomy. Disc herniation patients have scoliosis.
Yeah,
Postural
well,
scoliosis.
yeah,
Sciatic scoliosis.
yeah, yeah.
Sciatic scoliosis.
So thank you once again, all the faculties, especially Dr. Shankar sir, Dr. Chabra sir, Dr. Das, Dr. Abhishek, Dr. Neeraj, Dr. Arvind Kulkarni from Mumbai, and our president, Dr. Rupinder Chahal, and Dr. Dibudendu Mahapatra, the secretary. So the next webinar will be on spondylolisthesis, and we'll try to have some basics of spondylolisthesis with surgical tips and tricks. So till next time, see you all. Goodbye, good night.
Thank you, Guru.
Thank you.
Thank
Thank
you,
you all.
Arvind.
Thank you.
Thank you, Arvind.
And a special thanks before going off, a special thanks to our sponsors,
Yeah.
the Sun Pharmaceuticals. Rajesh, are you there?
Pawan hai.
Yeah,
Rajesh?
Pawan.
Pawan,
yes, sir.
and the team, backend team also, backend team. Hi, Pawan.
Yes, sir.
So thank you so much for being with us and helping us in propagating our knowledge and to rest of the people, younger guys, younger upcoming surgeons. I thank you all again for this lovely meeting.
Thank you
See
so
you
much, sir.
soon
Thank you,
next
sir.
month. Thank you so much.
Thank you, sir. Good night, sir.
Right.